Good morning, good afternoon, and good evening to everyone. Thank you so much for joining us today for this webinar, launching the Maternal and Perinatal Death Surveillance and Response Capacity Building Materials, supporting countries to strengthen MPDSR throughout the healthcare system. I'm Francesca Palestra, Technical Officer in WHO Geneva, and this is an overview of our agenda today. We will have an introduction by Dr. Anshu Banerjee, Director of Department of Maternal, Newborn, Child, Adolescent Health and Ageing in WHO Geneva, followed by Ms. Susan Stals, the Director of Maternal and Newborn Health, USAID Momentum Country and Global Leadership, MCGL. Then we will have a rich presentation launching the Maternal and Perinatal Death Surveillance and Response Capacity Building Materials, followed by a panel discussion, questions and answers, and closing remarks. So please copy and paste your questions in the chat box. We will take them and answer to your questions in the question and answer session at the end of the webinar. For this webinar, there are no translations available in any language, unfortunately. So for now, we will have it in English. So I would like to welcome Dr. Anshu Banerjee, our Director of the Department of Maternal, Newborn, Child, Adolescent Health and Ageing in MCA in WHO Geneva, to give the introductory remarks. Thank you so much. Over to you.
Thank you, Francesca. And I would like to welcome everyone to this launch today, including all our partners, and in particular Momentum Country and Global Leadership, or MCGL, UNFPA, UNICEF, the MPDSR Technical Working Group, but also our country partners, the healthcare professionals and country implementers, and of course our esteemed speakers and panelists today, as well as the general audience. I'd like to thank all partners for their support in developing this combined MPDSR, so maternal and perinatal disease surveillance and response capacity building package, which is updated with the latest WHO guidance. And in particular, I also want to thank MCGL for the financial support that they have provided to make this possible. So thanks to this collaboration with MCGL, UNICEF and UNFPA, already many healthcare professionals have received this training in the regions such as our Southeast Asia region, the Western Pacific region, in our Eastern Mediterranean region and the African region, with a total of 24 countries participating and 186 healthcare professionals receiving the training. And on top of that, also 39 professionals who became MPDSR facilitators. Congratulations to them. I would like to highlight why this is of importance. First of all, maternal and perinatal death surveillance and response is an essential quality of care intervention for improving maternal, perinatal and neonatal survival, and it is key in understanding the number and causes of deaths. We also know that factors enabling implementation of MPDSR include clear support from leadership, commitment from staff, and regular participation in meetings, and that these meetings need to be held on a regular basis. One of the gaps that we face in MPDSR is the lack of training and limitations around quality of reviews, appropriate coding of causes of death and analysis of data, and limitations in developing and implementing the recommendations is one of the issues that we really hope to address through training and through this package. So this new capacity building package combines the maternal with the perinatal death reviews and response, providing the latest evidence. It has updated forms and guidance to participants from the latest published WHO MPDSR materials to support implementation. And through this capacity building package, participants can also become MPDSR facilitators. As I mentioned already, 39 have become facilitators, and thereby train other colleagues to improve the MPDSR implementation as facility level. Moreover, this training includes elements to implement during the MPDSR committee meetings in order to avoid the blame culture. And we know that the blame culture has been one of the bottlenecks, let's say, around having a good MPDSR system. We hope that the materials will be used widely and will serve many countries. And we hope to disseminate further the new MPDSR tools and materials and help improving the quality of the reviews and recommendations to better inform policymakers and country implementers. So once again, welcome to all, and back to you, Francesca.
Thank you very much, Anshu. So now I would like to introduce Ms. Suzanne Stels, the Director of Maternal and Newborn Health at USAID Momentum Country and Global Leadership, MCGL. So in her role, Suzanne contributes to the global technical leadership and learning and supports the policy dialogue required for achievement for global maternal newborn child health, family planning, reproductive health goals through initiatives, strategies, frameworks, guidelines, and actions plans that have been endorsed worldwide. So over to you, Suzanne, for your introductory remarks. Thank you so much.
Thank you so much, Francesca, and good morning, good afternoon, good evening to everyone. Excuse me, it's very early where I am, but I'm very happy to be here, and it's my immense pleasure to participate and support this global launch. So Momentum Country and Global Leadership is a 5-year USAID funded project focusing on technical and capacity development assistance to ministries of health and other country partners to improve outcomes for maternal, newborn, and child health, voluntary family planning, and reproductive health care. So our primary objective is to build upon existing evidence and best practices to catalyze innovations that then enable government-led partnerships to deliver high-quality evidence-based interventions that accelerate reductions in maternal, newborn, and child mortality and morbidity at scale. And as Francesca mentioned, we contribute to global technical leadership by supporting globally endorsed initiatives, strategies, frameworks, guidelines, and action plans. Because of this mandate, we've had the opportunity to work closely with WHO, UNICEF, and UNFPA in developing the global MPDSR capacity building materials. I want to acknowledge and appreciate the collaborative efforts of the international agencies and the support of the leadership of USAID and Momentum Country and Global Leadership. With this close working relationship, MCGL was able to develop the virtual package for MPDSR to ensure continuity of capacity development for MPDSR during the COVID pandemic. Thanks to all of our colleagues, leaders and champions of MPDSR in different regions such as Southeast Asia, Eastern Mediterranean, Western Pacific, and Africa, and those countries for their crucial contribution and active engagement in pushing this initiative forward. Their strong support and advocacy for this instrumental approach to quality has been a linchpin in ensuring the implementation strength in the countries and regions. And because of this support, MPDSR capacity building activities were able to continue virtually throughout the entire global COVID crisis. And we understand we may not be completely finished with it yet, but we certainly now have a number of tools to address, excuse me, both face-to-face and virtual. So we'd like to express our gratitude and appreciation for the dedication and commitment of the frontline health workers and managers. And as we speak, the regional pools of facilitators that were developed are currently supporting further implementation of MPDSR capacity building activities at national and subnational level. So please join me again in acknowledging the contributions of our global and regional partners and leaders, ministries, professional societies, technical leadership at WHO and WHO regional offices, UNFPA, UNICEF, USAID, and our MCGL team for the tremendous work in putting this all together. So thanks so much, everyone. And back over to you, Francesca.
Thank you so much, Suzanne. So now we can move to the first presentation. I would like to introduce Dr. Kusum Thapa, Senior Technical Advisor at USAID Momentum Country and Global Leadership. Kusum has over 30 years of experience as an obstetrician and gynecologist in Nepal and the United Kingdom. As a senior technical advisor at MCGL, she has been actively involved in providing technical capacity development assistance to USA priority countries and contributing to the global technical leadership and learning. Dr. Kusum is a member of the WHO Technical Working Group on Maternal and Perinatal Death Surveillance and Response, and has been appointed as the MPDSR advisor to the government of Nepal during the COVID pandemic. She is also the past president of the Society of Obstetricians and Gynecologists in Nepal and vice president of the South Asian Federation of Obstetrics and Gynecologists. She is a regular guest speaker at the Oxford Global Surgery Calls and desk chairing Shifting Ethics and Advocacy in Global Surgery. Kusum Thapa, Dr. Kusum Thapa, today she will present the launching the materials and the maternal and perinatal death surveillance and response capacity building materials. Thank you so much, and over to you, Kusum.
Thank you so much, Francesca. Good morning, good afternoon, and good evening, everyone. Before I begin, I would really like to take this opportunity to thank everyone for the support, as this has been truly a collaborative effort. As mentioned earlier, can we move to the next slide, please? As mentioned earlier, this is an integrated maternal perinatal death surveillance and response global resource package, really to help support frontline workers, health workers, as well as subnational managers for proper implementation of MPDSR. As mentioned by Anshu as well as Suzanne, to really ensure continuity of capacity development, the two existing packages, Maternal Death Surveillance and Response Package, which was developed by USAID's Maternal and Child Survival Program, and UNICEF's Perinatal Death Surveillance and Response Packages, were combined into a single package. Furthermore, due to the COVID pandemic, this was pivoted to a virtual platform with updated guidance to include new COVID-19 modules. The MPDSR operational guide, which WHO launched in 2021, is an important reference material for this training. Some of the modules, like modules related to the blame culture, conducting a joint maternal and perinatal reviews, as well as linkages with quality improvement, is an integral part of this package. We incorporated feedback from the MPDSR Global Technical Working Group, USAID team, Momentum Country Global Leadership Team, UNICEF, UNFPA, and most important, participants from the field testing, as well as participants who really took part in this training. And I would once again like to really thank each and every one of you for your valuable suggestion and guidance, because without that, we wouldn't have come to where we are today. Next, please. Next. So this package has the facilitator's guide, a learner's workbook, and a PowerPoint deck to go along with it, as well as the reference materials. You can see here the contents of this package. And what is important is that this package was designed to be really interactive, it's participatory, and it's taken into consideration the adult learning principle. The package includes both formative as well as summative assessments, and the online Kahoot game was used for formative assessment, and participants really enjoyed doing that. So this has been very interactive, and it's been a combined effort from the participants as well as the facilitators to really increase the learning that is there. Next, please. So as I mentioned earlier, we have the facilitators package, and this includes the facilitators guide, which really has the session outline, session plans. We have a PowerPoint deck to go with it for the facilitators. There is a Zoom guide specifically for the facilitators, and the platform for mentorship, which is before as well as during the workshop and even post-workshop, is the WhatsApp platform. This has been used because the WhatsApp penetration in the countries we were training was high. And this is really flexible because you can use any other platform for mentorship, whatever is really suitable in your country context. Next, please. So we have a learner's material also. And this learner's material comprises of the learner's workbook. And the home assignments are a real crucial part of this capacity building package, which has a lot of case studies, exercise, because during the virtual workshop, which was just for 3 hours, we cannot cover everything. So there is a lot of background reading to be done and background work to be done before they really come for this. There is specifically a Zoom guide for learners, and the materials are sent to the learners 2 weeks ahead of the workshop for them to really have a look at it. There is a whole set of reference materials, and the pre-workshop is held 1 week before the real workshop. And during the pre-workshop, the learners get to know each other as well as they familiarize themselves with the Zoom platform. The workshop then is for 4 days and it's with 3 hours each day. Next, please. So this is a reference aid, and as Anshu mentioned earlier, correct assignment of the cause of death is really important. Job aids for ICD-MM, which you can see here. And next, please. And ICD-PM reference aids are there really to support correct assignment of the cause of death and really enable them to make things very simple for them to really do it. And the participants from the workshop have really provided very good feedback that they found these job aids very useful. And some of the participants also mentioned that they have now laminated that and put it in the committee rooms as a quick reference. Next, please. As mentioned earlier, we field tested this in collaboration with the WHO Regional Office of Africa, as well as with Momentum Country Global Leadership and UNICEF. We did this in 6 countries in Africa, which is Ghana, Liberia, Malawi, Eritrea, Zimbabwe, and Kenya. And there were a total of 13 participants. I would really like to again thank all of them for their contribution to really provide us with all the feedback, which has really made this possible. Next, please. So what has been our reach? And I would again like to echo what Anshu mentioned. During the COVID pandemic, from October 2020 to March 2022, we've reached a total of 24 countries. And these are the workshops which we've done. We've worked very collaboratively. And I always like to echo that alone you can go fast, but together you can go far. And this is a real example of the collaboration we had with everyone that really helped us, even during the COVID pandemic, to do what we have done. And we had 9 workshops in Sierra region. We had the pilot testing in the Afro. We had 1 workshop in Emro region. And working with the Asia Oceanic Federation of Obstetricians and Gynecologists, we conducted 2 workshops in the WIPR region and of WHO. And now with CRO and MCGL, we are in close coordinating with SAFOG to really implement this and cascade this further in the SAFOG countries. So the professional organizations have joined hands to really take this forward and support this endeavor of really trying to reduce maternal newborn morbidity mortality. Next, please. So again, we've reached huge number of participants. They've been trained, and just to highlight, these participants have been from ministries, professional societies, universities, like we had professors participating in this, UN agencies, and we had even staff from Momentum Country Global Leadership also. And this is the distribution of male and the female participants who really participated in this effort. Next. And as Anshu mentioned about the 39 facilitators, they are from these 13 countries. And they've really gone through a stringent facilitator development process, which I will, which is shown in the next slide. Next, please. So after the initial capacity building training, they also had they were encouraged to do the online PAHO MPDSR training, which really is help reinforce their understanding during this training. They then co-trained with a master facilitator before they did one training independently with minimal support, and then they became the MPDSR regional facilitator. So now we have this pool, and we can really tap from this pool. And as part of the training, participants also developed a detailed implementation plan to cascade this training in their own countries, and they are now ready to take it at scale and at country level. And I think Anoma might also be able to really tell us more about this. Indonesia and Nepal have already started their cascade training, and the Philippines Society of Obstetrician and Gynecologists is planning to cascade this in Philippines this week. And the regional facilitators whom have been really crucial in really helping support each other. So they've been supporting the regional training, they've been supporting the country level training. And what is interesting is from different countries, they're working together to really take this forward. I would also like to mention one very important fact is that this training and this virtual platform and the training which we've done has really helped to reduce absenteeism, because it's only 3 hours in a day, and the timings are flexible based on what the majority of the participants feel is appropriate. And there is very little cost involved in really doing these trainings. So even after the pandemic, as Suzanne mentioned, that this was really great for the pandemic, and we don't know how long this pandemic is going to be. But like even later, I think there is an opportunity for us to continue to a certain extent using this platform and making sure that we really build capacity of all our frontline health workers and subnational managers and facility level managers in this process. Next. One thing which I would really like to also highlight is the WHO operational guide, which I mentioned earlier, which was launched in 2021. The Annex 17 has an indicator catalog for monitoring. And what we've done is also working with the global technical working group, as well as with other partners, we prepared scorecards, which can be used by hospitals, by facilities, districts, and provinces to monitor the performance. I'll just show you the next slide. This is just the snapshot of the scorecard, and we've already started implementing this, as I mentioned earlier, in Nepal and in Indonesia, and other countries are also taking this forward. It has 3 categories of indicators which we are trying to monitor. One is the maternal perinatal indicators, which are 7 in number. Then there is the review indicators. We have 3 of them. And most important, where we found was the response portion, that is the weakest portion. We have been using evidence and recommendations, and we have 4 indicators just focused on the response and the recommendations. This will then enable facilities, enable districts, province, and even at a national level to really see where we have been having issues and tailor our approach to address targeted interventions to address that. So this is something which is we've started, and it's being rolled out in countries and at subnational levels also. Next, please. I think, thank you. Thank you. Over to you, Francesca.
Thank you very much, Kusu. So now we will go to the panel discussion, and I would like to introduce our facilitator, Dr. Tedbabe Degefi from UNFPA, from UNICEF HQ New York, as a senior advisor, maternal and newborn health. So she will introduce the speakers of our panel discussion. Thank you so much, Tetvabe. Over to you.
Thank you, Francesca, and thank you, dear colleagues, for giving me this opportunity to facilitate, to introduce our esteemed panelists and facilitate this session. We will learn a lot from our esteemed panelists. So I have two of colleagues, Dr. Anoma Jatilka, who is a medical doctor with expertise in reproductive health and in public health programs. Currently, she is working as a medical officer in maternal and reproductive health in the WHO Southeast Asia region. She holds a postgraduate, master's, and a doctorate in preventive medicine. Dr. Jatinka has over 30 years of work experience in maternal and reproductive health, including as a national program manager, maternal newborn health, with family health Ministry of Health in Sri Lanka, and 16 years work experience at the WHO country and regional level. She has been involved in MPDSR activities in various capacities for the last 30 years, and she is also a co-author of several publications. So I welcome Dr. Anoma. And our second panelist is Dr. Vanita Jan. She is a professor of obstetrics, gynecology at the postgraduate Institute of Medical Education and Research in India. She is certified. She is a certified robotic surgeon. She is in charge of maternal health surveillance and response. She is a co-editor of textbook for modular and maintenance clinical obstetrics various editions. She has published more than 130 papers, and her area of expertise is in high-risk pregnancy, gynecology, gynecology, and maternal health. So a warm welcome to our esteemed panel. So I will have a couple of questions for my the first round. So my first question goes to Dr. Anoma. So why did you see the need to implement MPDSR capacity building program in CRO? And also, how did you manage to involve country leadership in this program? Dr. Anoma.
Yeah, thank you for the question, and then thank you for the opportunity to provided to Southeast Asia region to share our experience in developing and implementing MDSR and MPDSR capacity building programs in our member states. So actually, it's a very good question. So why we have started this? As we know that maternal mortality reduction is maternal and newborn mortality reduction is a flagship priority in our region. As well as we know MPDSR is a high impact strategy for maternal and newborn mortality reduction as well as the stillbirth reduction. As of 2020, only very few member states were on track to achieve the maternal mortality ratio that related SDG target and some and also newborn targets and stillbirth rates. So while we are in this stage, the national policies are favorable towards the MPDSR in all member states. Yet, nationwide coverage of MPDSR implementation is limited to a few member states. And composition of the review committee and capacity to conduct review and quality of the review process and response systems needing a lot of improvement. Then at the same time, the implementation of MDSR is not MPDSR. MDSR has been identified as a key performance indicator in the region for measuring the organization's results. It's also provide high priority to MDSR implementation in the region. So based on the above reason, in 2020, Southeast Asia region planned a regional face-to-face meeting for MPDSR training and including MPDSR. And it had to be postponed indefinitely due to the pandemic. Therefore, as an alternative, in partnership with MCGL, Momentum of Country Global Leadership, we developed the first virtual MDSR training package in SIA and is piloted in our region, and then also refined and train trainees from all member states. As Dr. Thapa indicated, then after that it's developed as MPDSR, and then earlier we developed as MDSR. So this MDSR training package has expanded as MPDSR by incorporating the perinatal component in the Afro region. So we learned that the virtual training is very cost-effective methodology during this period. If program planned effectively and prepared facilitators well, the program's quality also not affected. That's what I think Dr. Susan also mentions, and then Dr. Kusum also mentions that we can even think later. Actually, we also thinking that even when the pandemic is over, even that this some of this learning can be implemented very well. So, and also how I managed to get the leadership of country leadership of this thing. So what we did, and then myself and my colleague, Dr. Rajesh Mehta, who was the newborn advisor that time. So we totally depend on WHO country officers. WHO country officers played an active role in advocating at the country level for MPDSR implementation and the need for capacity building with ministries of health and other essential stakeholders. This is because we are a 3-level of organization has to work together. And then we train all national program managers responsible for MPDSR, some members of the professional association, UNICEF, UNFPA country staff, and WCO staff, and some important implementing partners at the country level as teams. Then they were identified trainees further trained as facilitators as described by the Kusum. So this is how that we got the leadership. So that working as a teams, and then also advocating at country level, and then also policy level support, and then regional level support, I think it's helped us to go a long way. Thank you.
Thank you, Dr. Anoma. So my first round of question again, another one goes to Professor Vanita. Professor, why did you become an MPDSR facilitator? And what are the main opportunities you saw in the participants? And also, what challenges did you see? Over to you, Dr. Professor.
Thank you. Thank you for the question, Ted. And thank you for allowing me giving the opportunity to be a part of this whole program. Well, my journey as a facilitator has started almost, I would say, since 3 decades. I have been associated with maternal death review. I'm working in a tertiary care institute referral center in Northern India. So we have been doing maternal death review. I was initially associated as a junior consultant, and then for the last 15 years, I have been the in charge for maternal death review in this institute. So when I was nominated as a delegate for the first training, I thought we have been doing reviews and let's see if there is anything new to learn. But when I attended the training session, my perspective became very wide, and I realized that this program had been so comprehensive and scientifically designed and had a very clear framework. And as we have an ongoing program of maternal death review in our facility, I used the training that I got in that training session. I implemented it in my own facility, and I realized that the quality of a review really improved, and I was very happy with the results. So I realized that this training program and these packages had a lot to add to what we were doing earlier. The packages, as Dr. Kusum has said, that we have a pre-course before the package where we initiate the participants, we discuss the basics of Zoom platform, we discuss the importance of home assignments, we give reference material to the participants, and because of it, when we actually start the training, the participants are already initiated and very enthusiastic. So we start with the word go, and the program is very interactive. The participants are able to share their opinions, and we use the chat box for this, and we have small group discussions. With that, I realized that the training was very participative, and they were really interacting very well. And it was a very enjoyable training, I must say. Like Kusum pointed out, we have a Kahoot game for formative assessment. And we realized that the participants, although they were senior people, when it came to the Kahoot game, they all became childlike. They were so enthusiastic, and they participated and they enjoyed the whole thing. Then we had role plays where each one of us played the role of a member of an MPDSR committee. And we learned that the real life experiences, and we became better at arranging these MPDSR committees. So I learned so much from this, and I had that experience of maternal death review for so many years. And I felt that the training and the experience put together, I may be able to contribute some bit to improve train the colleagues in this MPDSR implementation, and I may be able to do some bit or at my part to achieve the goal of eliminating the preventable maternal deaths. This has been my passion always, and I feel that this platform has really given me the opportunity to do so. So that is how I became a facilitator, and I'm enjoying it thoroughly. Regarding your second part of the question as to the opportunities and challenges as far as the participants are concerned, I saw a lot of opportunity because most of the participants have been senior people. They have already been involved in MPDSR reviews. So when you have participants of that level, they really add to our knowledge. They let us know what are the problems which are faced in real life situations. So this training is not a theoretical training. Since we are discussing people who are already into it, it is a very practical approach, and it can be easily translated directly into the implementation. And these participants are senior, as I said, so we have been using the adult learning principle of building up on the known knowledge, and that is a huge opportunity. Regarding challenges that you said, yes, we know that whenever we have a group of people, some of them are not very expressive. So there was a challenge with a few of the participants, but the framework of this training is such that we have small group discussions, and that is where we get the opportunity to identify such people and encourage them to participate. Also, those who are not very confident in being vocal, they have the opportunity to share and interact their opinion on whiteboard, chat box. So this challenge is also overcome. One more challenge that I have always thought regarding the participants was that some of them are not very regular with their home assignments. And we can understand as adults, we are not used to doing home assignments, so which are very important in this training module. So, but we have been trying to emphasize the importance of home assignments. And I realize that as we go by from day 1 to day 4, things become better and we are able to overcome the challenges. So I think that's it.
Thank you, Professor. Really, I could see your passion, and we are really fortunate to have you in our team. So in my second round of question, if again, colleagues, if you become brief now, because we are now almost running out of our time. So again, my second round of question goes to Dr. Anoma. So how are you planning to use the database of the regional facilitators in your region? Dr. Anoma.
Yeah, thank you, Ted. I think just before that, I just want to add something about this training, because the way it's the job based on ICD-MM and ICD-PM was really, really good, because the people are thinking ICD-MM and ICD-PM is like a real terror and you cannot learn, but it was so simple that this job based, and that I think I need to be highlighted. So then this database, I think after completing this facilitator training, so after this training of main training program, then selected facilitators, we give another two days training as facilitators. And they are, so also then after that, they will work as co-facilitators in regional training. So after that, they are full confident in having their to conduct their national training programs. SIA has already trained about 75 trainees and 20 facilitators from health ministries, professional association, WHO collaborative centers, UN partners, and WCO staff in 10 member states. Already some member states have completed national and subnational capacity building programs, as Kusum mentioned, Nepal, Indonesia, and Timor-Leste, and in some part of India, they have already started their national scale-up training programs. And some of our regional facilitators now work as a global facilitators. Is now Vanita Jain is one example, and then excellent facilitator. So they are helping even the other regions. So then is actually this is a very rich database. You mean the pool of resource people, and then we are using at the region and then also country level as well as the global level. So that's what I want to be highlighted. Thank you. So over to you.
Thank you, Anuma. So my last question is for Professor Jain. So in your opinion, after the training, how do you see the country plan to be implemented? Can you give us, an example?
Thank you. Thank you for your question, Ted. Well, it is very important that the training is translated into implementation. So in our program itself, we have a session on the action plan, making of action plan, and a group of participants from a region, they are encouraged to make an action plan which is attainable in their country. So they make the plans tailored according to resources of their region, the health infrastructure, and local cultural beliefs. So they make a plan, and then that is presented, and we discuss the plan, and then after the training we have a follow-up of that the plan that they have made to see if there is anything else that can be added for implementation. So for example, in India we have so many states, and health is a state subject. So we initially divided the country into the 4 zones: south, north, east, and west, and for each zone we trained the representatives from each state. And once they were trained, then these representatives went back into their own state, and then they helped us cascade down the training right from national level to state level to district level to facility and then to primary health care. So that is one way of how the action plan is prepared and implemented, so that whatever is learned is passed down, cascaded down in each of the countries.
Thank you, Professor Jain. And I would like to again, enormously thank our panelists. This concludes, our panel discussion, and back to you, Francesca.
Thank you very much, Tetbabe, and to our speakers for the very interesting discussion. I know that there are a few questions in the chat, so now we will try to start answering to them. And please, if you have any additional question, please put it in the chat. So right now, our facilitator of the Q&A and closing remarks will be Dr. Willibald Ezek, the Global Maternal and Newborn Thematic Fund Coordinator of the United Nations Population Fund, UNFPA. So over to you, Will.
Thank you, Francesca, and thank you, everyone. So, before I start the Q&A, I just want to thank all the speakers and the facilitators, and, also Andrew, Susan for the opening remarks. I think it's really great. And if one thing came out that was positive from the COVID-19 response is, virtual facilitation and virtual capacity building. And I think this is just an excellent example for that. And it also shows that maternal and newborn health is coming more and more together, and this is exactly what we want along the continuum of care. I have the questions in front of me, and I would like to start asking Kusum if you are, I hope you can hear. There's 2 questions that are more generic, and they are, is the integration of midwifery very prominent, and can it be advanced? And the second one was, is there a plan to at some point extend the program also to child deaths? Kusum, over to you.
Thank you so much. Both really excellent questions. Yes, we've always been focusing as part of this training on a team-based approach. So it's a team of not only doctors, but it's a team of OBGYNs, pediatricians, nurses, nurse midwives, where there are no midwives, and also managers, including the data people. So they are all part of this training. And as part of small group activities, we always encourage team formation, working in team, and how each of the members of the team brings to the table their own field of expertise. So the nursing midwifery is an important part of the team, and we have the breakdown of the nurses who've been involved in that also. So yes, thank you so much for that question. And I think that is something which is very important. And if we really want to continue cascading this at country levels, it's important. We cannot do without our nurse midwives, and everybody has to be part of this team. So that's for the first question. For the second one, yes, expanding it to beyond perinatal. We have been in conversation, and Enoma is here with Dr. Rajesh Mehta from CRO. We were already in conversation of how we can still use the same platform and add on to the neonatal component. And internally at Momentum Country Global Leadership, working with our child health counterparts, we have already started thinking of how we can use this platform to add on to the pediatric death audit. And at MCGL, that is one of our real priority, and we're really working towards that. Yes, I think if we have a platform, we can continue building and expanding onto that platform. And it's easier rather than going taking things separate. It's better to get an integrated approach using the same processes as we move forward. I hope that answers your question. Thank you so much.
Great, thank you. And I hope this answer has been questioned. I have another question for Vanita. And the question is, can the materials be adapted right away, or is this an interim version? Is this the final version that we are going to see? And then the second question to Vanita also, how detailed are the contents in terms of the review process, for the training package? Maybe Vanita, you can take that question, those two questions.
Thank you, Will, for this question. The materials have been beautifully prepared and they are ready to use. So it's not an interim version, they're ready to use, they are very detailed. And the second question that you said was, if they could be, beg your pardon, what was the second question you said?
How detailed they are,
Yeah, they are very detailed. I mean, especially when these materials are, when used with the training program, they are all encompassing. But otherwise also, if you go through the materials, they have the review process, the the importance of data management, the importance of trends. Each one of them has been explained very nicely with examples and small short exercises which help us to learn and then test our own capability of doing, like how to find the cause of death, how to use the ICD-MM, ICD-MPM. All of these are given in great detail with short exercises and examples as well.
Thank you, Anita. And then I also have another for Anoma. There was a question where someone was saying that in the normal times, before the lockdowns and before COVID, there were certain incentives to attend workshops, the refreshments, and to come together and you would meet your colleagues and so on. But with the virtual part, these incentives are not there. Are there any concerns, or are we fine with that? Or how do we see the uptake? This is what our colleague was asking. How do we see the uptake of the virtual vis-a-vis the face-to-face?
Yeah, I think so. We didn't pay anything because it's a virtual. It's not allowed for our rules and regulation to pay for virtual programs because it's only 2.5 hours and for 5 days. And then we didn't pay any. You mean the things or no refreshment, nothing. Only the material we shared. but they were highly committed. And then even that sometimes Kusum, we have to restrict, because the virtual training, we cannot accommodate about 50-40 people, but sometimes that they really wanted to include another 5 people, and then we were really have to cut down. And then next training is we are planning in next week. So I'm really having issues now because some countries want to send several people. So now they understand it's very good. And then also at later, I have paid very nominal fees for the facilitators, but I don't say it's a honorarium. So that's also based on our requirements. So we didn't have any problem. Only problem we had is how to accommodate that so much of demand from the trainers, and even the facilitator training programs we have to cut down because we have to give the hands-on practice. And there was a high demand. So I think that's why even at the beginning, we also thought that it may not possible because of this virtual platform, but they accepted it very well. I hope I answered your question.
Yes, thank you. We have a little bit of time, so maybe I go on for another 1 or 2 questions probably. So Kusum, again, coming back to you, there's a question, do we follow up with the facilitators and with the facilities to analyze how it's impacting on the ground, how so the tracking and the analysis of MPDSR, how is the follow-up happening after this? Is there a follow-up? Are we tracking it? Whether it's really making it on the ground?
Thank you so much. Thank you so much. Yes, that's always in the plans. We always make sure that we follow up. And in fact, like what we also do is, as part of the regional trainings, we make sure that our facilitators are also really have continuous hands-on practice. So it's not the same facilitator we are using for all the trainees. We give an opportunity for different facilitators based on their availability. So that is how we keep updating our facilitators in that training. Regarding tracking at country level, we've just started the implementation and we are trying to use different methods. One is we ensure that the trends, looking at aggregated trends, is something which is an important part of our capacity building, and we encourage facilities to also really look into that. And the other thing also is like the scorecard itself. We are hopeful that using this scorecard will really help us monitor the performance of the facility. So we've started introducing scorecards, and it's going to be in a web-based system in some countries. Like, for example, Indonesia has already started thinking in one of their provinces to really put it in the web-based system. And also important is how we are really trying to make sure that the linkages between MPDSR and quality improvement committees really are happening at facility, district, province level. And for that, what we also think about is the linkages between the MPDSR committee and the facility and the quality improvement committee, so that the response portion is taken by the quality improvement committee, and they can implement and evaluate and then again come back, and together they can work. So these are different ways in which we are trying to really ensure that this the response portion is also really implemented. And I think, Anoma, you have something to mention?
Yes.
Yeah. Yeah, just adding it, in the region, we have developed some checklist, and then we shared with the WCO focal points, and then we looking at even the quality of review, and then also national plans develop, and then we are monitoring through that also. And I think we need a lot of monitoring, we understand, but yet we have initiated it. I feel that this the scorecard will be very, very important to be implemented in the settings. Thank you.
Thank you, Norma. Thank you, Kusum, and thank you, Anita, for answering all these questions. I think they were super interesting. There's more questions. Unfortunately, we cannot answer all of them, but there's for sure follow-up. And we have a next slide, I think, Francesca, if you can show that. So because there were some questions about the follow-up and what's the next steps, and also who can be contacted. And you have here the email address of Francesca, who's with the rest of the team in WHO have kindly facilitated this, so you can also reach out here for further questions. So what is next? We're working with the regions and with the countries and the MPDSR technical working groups and the partners to cascade down the trainings to country level. And so we can also monitor the framework. And this was also the last answer, the last question that we have and the answer. So well, how do we track it? So we also want to monitor the results, and eventually we want to see reductions of mortality rates, of course. The capacity building materials will be shared with you soon. They are not available yet here right now, but they will be shared. Also the slide deck and the recording that was taking place today will be shared with you. The materials will be on the WHO websites. The recording is available here, and you can probably, this will also be shared, so you can go to the recording onto the slides. This will be done by Francesca, and also go to the Quality of Care Network website. There will be also some material, and Quality of Care and MPDSR, as you know, is very much linked with each other. And, if you're interested, please contact Francesca and the team in WHO, but of course, all of us who are involved from the UN agencies, but also from others who have been spoken, are happy to respond to any questions. So with this, we have another 2 minutes. I think this was an excellent, another step towards such an important topic in maternal newborn health along the continuum of care. And as I was saying, I think it's great that we take advantage of the new normal, which is more virtual, more webinars, and more telemedicine also. And I think it's great to build on this because it will continue to be with us, and it's an excellent opportunity to reach those who we were not able to reach necessarily before, who we had to bring into rooms to educate them, to help them. But now with the new technologies, we have more opportunities. And also in MPDSR in general, I think it's so important to review how things have taken place, why something has happened, why a death has happened. And here, and it was mentioned, the blame culture is very important to be avoided. And we have to continue to work on that and make sure that people are not shying away from MPDSR efforts, but embrace it. And not shying away from it means that there is no blame, but more technical discussion and professional discussion, and also constructive discussion that will help to find out what went wrong and how we can improve next time when we are in a facility or even in a community health center where we have a death. So with this, I think I would like to thank all of you. Thank you for attending. We had more than 300 participants. It just shows how many of us are interested in this. Thank you for your interest. Thank you for your questions, and thank you for the panelists for answering all the questions. See you next time, and have a great day. Bye.
Thank you, everyone.
Thank you.
Thank you, everyone.
Thank you.
Thank you so much.
Thank you. Thank you.
Thank you, everyone.